today we will read chapter number 85, that is metastatic lesions or metastasis to liver. This is a very important chapter. Okay, why important? Because the basic management principle of HCC and basic management of all liver lesion are almost same. So I found it very interesting and important. Let us see how the chapter unfolds. So first important thing is anatomy. Liver anatomy is a favorite question. So we have a liver which has right lobe, a left lobe. Right lobe is larger one. Then we have this IVC. Let me make it from blue color. IVC. Then aorta. We have biliary system, green. So I will just draw this right portal vein. Sorry, not biliary, portal system. Right portal vein, left portal vein. Okay. Then there is, from this aorta, there is right hepatic artery. Then there arises left hepatic artery, and there is middle hepatic artery. Okay, so this system is the system of supply to the liver. Okay, this divides liver in two hemi liver, like this middle hepatic artery. So from the IVC area to the gallbladder area, there is a ligament that is known as primary scissura or Cantley line. So what is important is the division is marked by middle hepatic artery. So middle hepatic artery runs in the primary scissura and it forms one right, one left lobe of liver. So these are two hemiliver. Now with the blood supply, there comes further division. The one division is, there is a division of umbilical fissure. Umbilical fissure, where this left portal vein is actually running like this. So left portal vein runs in umbilical fissure and it further divides the left side into two parts. Now right side, this right hepatic vein, when we are talking of venous system, this all vein will go to IVC. Okay, so here right, left, everything goes to IVC. So the right hepatic vein and right hepatic artery, this right hepatic vein divide into then again two parts, anterior and posterior. So right side is anterior posterior division, left side is medial lateral division. Now further division is there. So this again I will just make some boundaries. One segment, two segment, then this three segment, and then at the back there is four segment, then 5, 6 part, and at the back there are 2, 7, 8. So there are 8 segment. Now I think it's clear that major division is made by middle hepatic artery, which divide into right and left, then left portal vein here for the left medial and left lateral, and right side, this right hepatic vein, it divides into anterior and posterior. Now the numbering of the segment, the first segment is caudate lobe. Caudate lobe is at the back. Okay, it's between portal vein and IVC. Caudate lobe is a separate lobe. Okay, so that's most important part. So caudate lobe will be like this, back. Then it start with number 2. Okay, number 3, and whole front is the 4th lobe. Okay, then here we go 5th. Behind the 5th is 6th. Okay, then above 6th is 7th, and this front is 8th. So the sequence goes like 1, then 2, then 3, then 4, then 5, then 6, then 7, then 8. So this whole sequence of liver part is there. Now why it is important? Because we have to dissect the metastasis lesion. Then we have to follow the anatomy of liver. So each lobe is supplied by one part of arterial and venous supply and portal vein. So we need to know this majority of part. Now what about this, how this is working? So how liver is working? So there is one good diagram. I will just make it slightly, it will take some time to clear it, and I think it's important. So if we look for cells, so this is cell line. So here is the biliary part. Okay, so this one is portal vein. Portal vein, where the blood flow in this direction. Then this sinusoidal cells, and from this channel there comes this biliary radical. So bile is secreted by these cells, canalicular. Then there is one arterial system also. Arterial system is hepatic artery. So hepatic artery, portal vein, biliary system, these three are there. They form this type of channel: hepatic artery, biliary tract, portal vein. Okay, these three are present in a hexagonal method fashion. Okay, around the liver canaliculi. So let me rapidly make it. Then there will be one hepatic vein. So all these drain to hepatic vein. So these triad. Now why this is important? Because see, there are oxygenated blood is only present in the hepatic artery. So the oxygen level is maximum near this triad. Okay, this is zone 1. Then there is zone 2. Zone 2, 2. Then this is zone 3. Zone 3 is near hepatic vein. Zone 3 has poor O2 supply. So a hypoxic zone, more prone for necrosis and damage. Even paracetamol, chemotherapy, any related damage of hepatocyte is happening, zone 3 is more vulnerable. Now with this information, we have some idea of how liver anatomy is there, how is this triad or portal triad is there. So there are 3-4 type of channels are there. So just revise it. There is hepatic artery that gives the oxygenated blood to the liver. Then there is portal vein. Portal vein from the intestine, superior mesenteric vein is there, which get attached with the splenic vein, makes the portal vein. So portal vein takes the blood, from alimentary canal, that is GIT, to liver. Hepatic artery takes from aorta to liver. Okay. So then there are third type of channel, hepatic vein. So it drains blood from liver to heart. That's a proper venous system. Okay. Portal vein is actually not taking blood out of liver, it is providing blood. So it's type of dual supply. Hepatic artery and portal vein both are blood supply which is reaching liver. Hepatic vein which is leaving liver. And then there is biliary radical. So bile is secreted by canalicular cells and it drains into common biliary duct, then biliary duct to our ampulla of Vater. So whole biliary system is there. Now peculiar things about liver. Peculiar things: point, dual blood supply, okay, and regeneration power. Regeneration power, even 20% of liver can regenerate. So even 80% removed, the 20% will slowly regrow. So in Laban Valley, there is a literature like some demon was tied over the rock on the hill when eagle and vultures were eating up liver every day, and next day it was regenerating. So liver can regenerate, not so fast, but yes. So these 2 points we will keep in mind when we are managing any liver disorder. Now dual supply, elaborated further. This hepatic artery gives a high oxygen, high O2 blood. It supplies these cholangiocytes, that is biliary radical bile producing cells, while the portal vein, which comes from alimentary canal, that is GIT, rich in nutrient, it supplies normal hepatocytes. So what about metastasis and lesion? This, even the primary tumor like HCC or METS got supplied by hepatic artery. So this is important because now we have disease, that is metastasis or primary liver tumor, supplied exclusive by hepatic artery. So we can just cannulate the hepatic artery and reach the tumor point. Even if we are blocking it, the portal vein will sustain the normal hepatocytes. So blocking of hepatic artery is feasible, like we are doing is TACE. So when we are giving chemotherapy, we just trans-arterial, so we block it and then give the therapy or beads therapy or whatever you want to give. So this dual supply is important. Now regeneration, dual supply, two important things. Coming to the proper chapter, this was the introductory part. Okay, it took quite a long time, but I found that this is very important to know. Now, liver is a common metastasis site, common metastatic site. Okay, three subset we can divide, which is important. Colorectal carcinoma, that need special mention, we will discuss at the end. The neuroendocrine tumor or carcinoma of GI pancreas, that has liver mets proponicity and others. So liver is common for colorectal or for GIT and also for breast, melanomas, other part also. Now how to look for it? Imaging. Which imaging modality is better? So we have USG. I will just rush through it. USG is handy, cheap, available, low sensitivity, cannot pick up a smaller lesion, very useful for image guided procedure. So when we are doing biopsy, when we are doing some microwave ablation, we are going to put the probe, USG will come for the help. So this is for USG. What else we have? We have CECT, that is triple phase. This one is important. Okay. So what triple phase means? There we are giving dye. Okay. So there are phagic images we are taking pre-dye insertion. So this is non-contrast phase. Non-contrast. This is called early phase. So before giving the contrast dye, okay, early, then dye is given. So it will be arterial phase, 20 to 30 seconds of the dye infusion. Then venous phase, 60 to 70 seconds. Okay. Then delayed phase, 3 to 5 minutes. So actually it's not triple phase, it's 4 phases. One phase is before giving dye, then there is some 20 to 30 second time when the arterial phase. So we are giving dye in venous system, cubital vein. It will go to heart through the channels. It will go to lung, go to heart. Then it will come in aorta. Then arterial phase will start. So with each heartbeat, the dye is going to arterial phase. It will go to hepatic artery. It will reach the liver. Okay, that's what the arterial phase is there. That same arterial blood is going to GIT. Okay, and then making the portal vein and coming to the liver again. So that will take some more time. So 20 to 30 seconds, the hepatic artery will reach. The venous phase 60 to 70 seconds, and then by 3 to 5 minute delayed phase means all the supply should go through hepatic vein back to the out of the liver. Now how to interpret it? So see, arterial phase is very important. Here we see hyperenhancement, because hepatic artery is getting the contrast, and the contrast actually make it hyperintense. So enhancement is seen as neuroendocrine, METs, HCC. These things are hyperenhanced. Then comes the venous phase, or this venous phase is 60 to 70 seconds. And here we are, what we are looking, they also cause portal phase. We are looking for this enhanced, hypo enhanced. So the lesion look darker. Okay, and this is a washout. So hepatic supply is gone. Now portal supply has come up, and plus minus capsular enhancement is stay. So then by delayed phase, everything will go. Now this thing, what the interpretation says, if HCC, this is triple phase finding is hyper enhancement in arterial phase. Okay, this delayed washout in venous phase or portal phase, it become hypodense plus minus capsular enhancement. But if we are looking for liver mets, HCC is a primary liver mets, it is best seen as portal or venous phase as hypodense. Venous phase is hypotense, not intense. Okay, and peripheral rim enhancement. Then if we are looking for hemangioma, because it will also enhance. Now then arterial phase, peripheral nodular enhancement, portal phase, progressive centripetal filling, and in delayed phase, stay. This is called blood pooling. So blood pool behavior. So hemangioma, even delayed washout is not there. So this the three main DD. Okay. So even we can look for hepatic adenoma. Adenoma is non-cancerous, so benign type of tumor. It has arterial enhancement, but no washout in portal phase, like HCC has. Okay. So that's the interpretation of CT scan. So we have seen ultrasound mainly for procedure. CECT very useful. It can differentiate, and that's the gold standard. We want to do CECT. Now the third thing, what we can do MRI. Where we can do MRI? When we want to look for the relation of blood vessel, capsule, so soft tissue relations when surgery is planned. If we want to remove this metastatic focus, get an MRI done. Then PET CT. So must get a PET CT, must get PET if surgery is planned. So sometime in 1/3 of cases, that is 30%, extra hepatic lesion is present, noted, and a futile surgery has been deferred. So PET CT is also good. Then we can take dotatate gallium-68 for this neuroendocrine tumor. Okay, so neuroendocrine tumor, SSTR positive is there, so dotatate can be done. These imagings we can do. So with this imaging we will get some idea, number of lesion, site of lesion, planning of surgery, whether any extra hepatic disease is there or not, and thereafter we will plan a treatment. Now coming to treatment part, what we can do with the MET focus. Okay, we have seen in previous chapter of brain also, lung also, that we have few modalities. Okay, one is surgery, the other is RT, and the third is systemic. We have only 3 modalities. Okay, the advancement has come in different modality. Now the most important is surgery. So hepatic resection, if possible, is choiced. Okay, you remove the tumor, R0 resection if done, and leave functional liver. These 2 things are important. You remove the tumor as such, and you leave the functional liver. So what is functional liver? This is called functional liver reserve. So whatever amount of proportion of liver we are going to leave after the hepatic surgery is of paramount importance. So a normal person, even 20% is sufficient, but on chemo, 30 to 40% liver mass should stay to sustain the life or to regenerate, and for cirrhotic 50%. So cirrhosis, 50% of liver should be staying FLR, that is functional liver reserve. For normal 20%, for chemo 30 to 40%. So this FLR, there are criteria of surgery. The criteria is very simple. FLR is a liver part which remains after surgery. It must be, there are 4 points. It must be vascularized. Okay. It must be having biliary drainage. It must be having venous drainage. And it must be adequate in size. So these are logical demand for this FLR. If they fulfill it, then only go for surgery. Vascularized means that liver remnant, whatever is going to stay, must have hepatic artery and portal vein supply of that part. Biliary drainage must be there because bile will be formed. Venous drainage, hepatic vein must be draining that area, and adequacy of size, as we discussed, 20% in normal or 50% in cirrhotic. So, but liver surgery, liver resection is not a simple resection. It has a mortality of up to 5%, and in high volume center only it can be done. So now complication, whenever we are doing surgery, the complication for the liver surgery are slightly different. So one is back bleeding. Back bleeding means we cut the liver, the IVC and hepatic vein, they ooze out. from the liver. So to prevent this, what we can do, you reduce the pressure. Reduce pressure of IVC and hepatic vein to 0 to 2 mmHg. So it will not push any back bleeding. Okay, so that's one complication, back bleeding. The other is biliary leak. Sometimes patient require a drain there. Then hemorrhage, not due to back bleeding but due to vascular nature. So liver is full of blood, so vascular nature, hemorrhage is there. Here come the handy Pringle maneuver. So it says that portal vein, hepatic artery, these both are there in porta hepatis. So you just pinch for some 20 minutes maximum. So if you pinch that, the blood supply of liver will go down and do the surgery. Then release for 5 minutes. If surgery is long, again pinch. So by occluding the portal vein and hepatic artery at porta hepatis, a liver supply is decreased for the blood, but up to 20 minutes it's not going to cause necrosis. So by this time you can do the surgery, or you release for 5 minutes, then again go for 20-minute window. So this is about liver resection. We do the segmental resection. It's not like a wedge. So a segment 1, 2, 3, 4, 5, 6, 7, 8 is there. So the concerned segment will be removed. Now, if surgery is not feasible, or if lesion is not small one, so we can go for thermal ablation. Nowadays microwave ablation is being done. So it can be done as isolated treatment or pre-surgery. Pre-surgery means you do the thermal ablation, reduce the tumor, then surgery, remove it. So it will become, the tumor will become less vascular, more confined, and you can do surgery. Then there is a concept of FLR, what we discussed. So it's not always necessary that functional liver reserve is more than 50% or more than 20%. Sometimes we need extensive surgery. So methods of increasing FLR is very important. Functional liver reserve can be increased. We take the help of regeneration power, because anyway FLR is going to regenerate. So we take the power beforehand, like this thermal ablation what we were reading. Pre-surgery, if we do thermal ablation, one thing the tumor will shrink, the other thing the other part of liver will take time to regrow because some part has been ablated. Now then portal vein embolization. So you embolize the diseased layer, embolize diseased segment. Okay, so that segment will shrink and the other liver part will proliferate. So here the FLR will increase. So by doing this portal vein embolization, a normal liver part is hypertrophied now. So you check for 3 to 4 weeks. Once you put the embolization of the segment, then 3 to 4 weeks, you check for FLR again or hypertrophy. Better term is hypertrophy here. Surgery has not been done. If hypertrophy is there, that's an indirect indicator also that the functional residual liver volume will actually going to replace the full liver after resection. If it is less than 5%, that's a poor regeneration capacity. So put the high risk for the surgery or no risk. So it works like a stress test. So thermal ablation, then portal vein embolization. This is mainly not a curative for surgery, but to enable the surgery by doing shrinkage of the segment and compensatory hypertrophy of the remaining normal part. It also works as a stress test. So if more than 5% regeneration happen, hypertrophy happen, probably the liver has more regeneration power. So surgery is okay. Now, similar to portal vein embolization, there is a method of associating liver partition and portal vein ligation for stapled hepatectomy. This is ALPPS. So one small paragraph is given about this in DaVita. So it's like associated liver partition. So do a surgery, do a partition of diseased segment. So not complete removal, just partition, just dissect the fibrous part and then ligate portal vein for that segment. So you do the ligation, not embolization, ligation of that part. So this segment will become thin, dry up or necrosed. Okay, then you remove it. second surgery, and there is hypertrophy of other area, so functional liver residue will increase. So thereafter a surgery can be done. So it is helps. Now the other method to have this increase FLR is two-stage hepatectomy. So you remove some of the meds, surgery, then allow FLR increase, then do second surgery. Okay. So what we are reading right now is method to increase FLR. Okay. We have thermal ablation 1, portal vein embolization 2, then associated portal vein partition and portal vein ligation 3, two-stage hepatectomy 4, and these are major thing. So by this, and there are other also like 5 RTL, 6 intra-arterial treatment. So these all methods are for increasing FLR. They can be used isolated or they can be used as a pre-surgery maneuver to increase the FLR. Okay. So now what is about RT? So we have various methods of giving RT. I will label the SBRT is the preferred one. Okay. It started with 6 to 10 gray single over 3 to 5 fraction up to 60 gray in 3 to 5 fraction can be given. Now problem is with gut. So in the right side of liver there is lot of intestine, colon is going, small intestine is there. So this gut toxicity is paramount. So we have to do a MRI based planning. Gut has a tolerance of 24 to 30 gray only. So this SBRT is very good ablative therapy for a small lesion in the liver and who is not fit for surgery. So again, like FLR in surgery, we want 700 ml of liver volume which receive less than 15 gray. So it should not be like whole liver has been irradiated. Okay. So this RT one part is this. Then there is palliative whole liver RT. Now SBRT also increases FLR for the later surgery. Palliative whole RT has nothing to do with FLR. But when we are discussing RT, we will just put note like 8 gray single fraction can be given or 21 to 30 gray and 7 to 19 fraction can be given. It is okay to give. Only side effect is nausea and transient transaminitis. Okay. It relieves pain and stress symptoms. Liver stretching symptoms can be removed. Now the other important part is intra-arterial treatment. Again, intra-arterial, like hepatic artery has exclusive supply to meds and HCC. So tumor supply is by hepatic artery. It can be cannulated. So it can be delivery of chemo or other toxic substance to target. So it's a targeted type of delivery. So it's like exclusive for that branch. We cannulate the hepatic artery, then we can give. What we can give? We can give chemo. Okay. This will come when we are discussing colon. We can give transarterial chemo embolization. Okay. So you cannulate the hepatic artery, block it, give some chemo. Transarterial, then is embolization, plain embolization. Then this thing of chemo. And you can give SIRT. SIRT is selective internal radiotherapy or TARE. SIRT is an umbrella term, but nowadays only TARE is being done. So radiotherapy by giving targeting the this lesion. So I hope that we are clear with the how we are going to do the TARE test. So suppose it's a tumor and this hepatic artery branch is supplying tumor. Okay. We are going to cannulate this. Okay. Now block this, and distal to block you give the supply. Either it is chemotherapy or TARE or TACE. So through the capillary we block the hepatic artery. Now the normal liver getting supplied by portal vein. So only tumor will be hampered. So and how we are doing this SIRT is TARE. So they are microspheres or glass beads or resin beads on which yttrium-99 is attached, and as cannulated hepatic artery is being used for TACE, we are going to use this, deliver this. Okay. So this emits beta rays, and beta rays has some 5 to 10 micrometer radius it can ablate. So that's how the tumor is selectively ablated. Okay. Now before giving this yttrium, we are checking, because the hepatic artery, the hepatic vein is the sole supply. It will remove the yttrium and hepatic vein will go to lung. throughout. So we look for the activity at pulmonary scan. It should not be high, otherwise there are chances of toxicity. Okay, and we can also do FLR mapping, how much functional liver is staying. So this is about SIRT. So what we have read, we can do surgery, we can do radiation, and we can do chemotherapy also directed there. So these method of increasing FLR, these are the basis of treating metastasis or the primary liver disease. Now coming to why we are interested in looking for CRC, colorectal carcinoma with liver mets. So colorectal has some peculiar thing, only liver mets is possible. So it's possible like the patient is having colorectal with oligomets involving only liver. So then intent is curative, remove or ablate or handle, better word is handle the mets. Okay, earlier it was known like do the PET CT, if extra hepatic mets present, no surgery. But now with advancement, this notion has changed. Remove that lesion also. So suppose we have combinations like you have liver 1 or 2 lesion plus lung 1 or 2, do the surgery. It has better outcome than liver plus peritoneal when we do surgery. So this is better than this liver plus retroperitoneal node. We can do surgery but has the worse outcome. Okay, so that's about the peculiar thing about CRC. Now what we are going to do with this liver met, whatever we have read till now as a principle, we can do that. So what else, what are the options? Once we decided to tackle this metastasis lesion, surgery, hepatic resection. Okay, now R0, that means we want a complete resection, 20% get cured, although late relapses are common. So hepatic resection is preferred one. Okay, and check for extra hepatic mets. If there, you remove that also. Earlier the notion was there not to remove. We have discussed that. Now, if patient is not fit, a smaller lesion, we can do microwave ablation. Okay. Now, if lesion is large or we have done the surgery, then what is the role of adjuvant? Chemotherapy. It only gives DFS benefit 7.3%. Okay, no OS. So a good surgery is the most important thing, and the chemotherapy in CA colon or in metastatic CA colon is just giving DFS benefit, not OS benefit. If we can do surgery, obviously we can't do surgery, then we have to give chemotherapy. So ideal is adjuvant is good to give, but with the notion that OS benefit is not there. Neoadjuvant or perioperative, so giving some chemo, then do the surgery, that is hepatectomy I am talking, and giving plus minus chemo thereafter. So there are benefit, like the benefit are natural one, but we know that chemo response, okay, then shrinkage of tumor, better surgery plane. But there are two unusual things I know, that they say it delay surgery so that impending widespread mets are noted. So suppose we are giving chemotherapy neoadjuvant, and by the time surgery is there, if it is already metastatic to many places, probably that surgery was also going to be futile. Moreover, adjuvant chemotherapy sometimes is not easy after hepatic resection, so we complete the chemo first hand. So no need of adjuvant, or poor tolerance is a better word, poor tolerance to adjuvant. So these benefits are there. So what are the losses? We are giving oxaliplatin, which causes liver fibrosis, which can increase spleen size, leading to pancytopenia. So liver damage is one thing, and fitness to surgery can go down with the chemotherapy. So neoadjuvant is plus minus benefit. Now when we are planning to do the surgery, again like we discussed, we have to increase the FLR by all these things, either chemo, portal vein embolization, SBRT, or tear, or TACE. So you do this thing, increase the FLR, then go for surgery, or do the 2 stages, hepatectomy, is also going to increase. Okay. Then systemic therapy, people have tried with this Folfox. Considering Folfox as base, we have tried adding cetuximab, and what we found? No benefit. Okay, we tried having bevacizumab, we found is good benefit, but need 5 weeks gap from surgery, either side. Then we tried with immune checkpoint inhibitor, and we find that no benefit. So more or less, we left with this Folfox and bevacizumab for that part of therapy. So that's how we are going to manage this hepatic. So we discussed for the resection and adjunct to the resection. But what if resection is not possible? We can go SBRT, TACE, tear, radioembolization, or we can go this hepatic artery chemo. That's the FUDR is the drug which have very high first pass metabolism in liver and convert to 5-FU. So cannulate the hepatic artery and give FUDR, it will convert to 5-FU, and that will cause damage to the tumor cell. Now the thing is, it can cause thrombosis to hepatic artery. We are cannulating giving chemo, and it can have systemic side effect also. So spill to the whole liver or off-target effects are there. Then if we are giving this TARE or SIRT, can we combine with chemo? So the answer is no, because the study has shown there is no benefit for TARE plus Folfox. No benefit. Study is ongoing for TARE plus Folfiri. We don't know. Then there is one important thing, disappearing mets. So suppose chemotherapy has been given in a neoadjuvant or perioperative chemo, and mets vanished. So we all know that MET is there and it is not visible. So response is good. What to do? To do or surgery or not? Surgery or not is dilemma. So around 1/5 will go remission. So some part, 20% will not require any surgery. Even without surgery they can sustain. But majority relapses. But the relapse is distant. So even if we are doing surgery, probably the distant relapse is hard to prevent. So more or less, not doing surgery is also okay. But the book says that it's a dilemma. Now prognostic factor. Prognostic factor, MSKCC make a prognostic factor, that is clinical risk score. Clinical risk score, although the relevance of this risk score is not there now because of the advancement in therapy. Now it has 5 risk factors like node positivity. Okay, with the primary node positivity is there, like the METs are synchronous or less than 1 year from the primary diagnosis. CEA more than 200 nanogram per ml. Then tumor size, that is liver mets. We're talking about liver met size more than 5 centimeter, more than 1 tumor. So it's a multiple disease or multifocal disease. Now importance is not there. The other part is ctDNA. It has come up in a large way, although not yet recommended. But I will urge you to listen a ctDNA discussion. It is there, I think, on YouTube, this Oncology Beyond Obvious. It's a very good channel run by Mumbai Group. They discuss the advancement. A journal dissection is being done. The ctDNA is beautifully explained. So as of now, not in practice, but it will come up. Now this is about how we are managing this CRS with liver mets. Then the other part is neuroendocrine tumor of GI pancreas lesion and liver mets. This is the second important group. Why it is separate and why it is important? Okay, so it has diffuse pattern of liver involvement. Like colorectal was solitary or oligomets type. It is diffuse. Okay, it can stay months to years without symptoms. So it is indolent in majority. The chemo options are very limited. So only platinum with etoposide. That's the only advancement one is seen, and there is no further advancement. So chemotherapy options are limited, and even liver mets, they secrete hormone systemic effects are there. Okay, so management surgery. Surgery, the peculiar thing is because it is diffuse pattern, so majority of time it is cytoreductive surgery. In colorectal, we were discussing of R0 resection. It is cytoreductive surgery in majority of time. There is no RCT to compare whether cytoreductive is what benefit it is giving. Seems good and seems feasible and seems like this cytoreductive surgery is going to be beneficial also. Now again we are going to do this FLR assessment, and you can do ablation, portal vein embolization to increase this FLR, okay, before surgery. Same principle will apply. Now we left with systemic therapy. So systemic therapy, we have this chemo, this platinum plus etoposide, then SSTR analogs, somatostatin, then there is PRRT, that is this lutetium therapy, and then there are target like sunitinib and other thing. So these are also options because of the slow growing nature. There is no hurry to just ablate or just do surgery. We have options of thinking this. Then we can do TACE, transarterial or TARE. So radiotherapy also. Or because of the diffuse, it is hard to give SBRT. So SBRT is less likely an option. Okay. So TARE, TACE, these can be done to the significant number of large size tumors. So this is about neuroendocrine. All others have no clear guideline, no clear consensus. Like how to treat breast. So breast with liver mets, systemic therapy is choiced. Systemic, hormone, HER2, whatever, depending on the tumor primary. But we can do surgery if there is oligomets, 1 or 2 lesion is there, other response are good, you can do. uveal melanoma, no surgery. It's a diffuse miliary pattern. Miliary pattern, so only chemo. Okay, sarcoma, it depends. Surgery is also beneficial. So small lesion, TACE, TARE. So the thing is, all other, apart from this colorectal, which is peculiar thing of oligomets only to liver, and neuroendocrine, which is peculiar thing of diffuse pattern, or cytoreductive surgery is beneficial. All other, there is no guideline. So that's all about this chapter where we are discussing the metastasis to liver, and we discussed about surgery. The basic concept of FLR, functional liver reserve, is most important, I think, and then we must know that what all we can do. So if we scroll like the basic, we are repeating that's only. So FLR increasing procedure, hepatectomy, we can do FLR. This 4 criteria we must know, that the vascular supply, biliary drainage, venous drainage, adequate in size should be there. And then we have thermal ablation, increasing FLR, thermal ablation, portal vein embolization, ALPPS, the 2-stage hepatectomy or SBRT or intra-arterial therapy. These all can increase FLR for and can be used as an isolated agent also. So this is all about the chapter. I think anatomy part is difficult or most difficult, but this is all what is written in DaVita. Thank you.